I was diagnosed with stage 2A breast cancer and I was shell-shocked. If you don't replace the hormones, you better damn well have a good reason why you're not. And if you absolutely can't, well, then you have got to be all hands on deck. But this flies in the face of what the guidelines tell us to do. And there's so much fear.
Dr. Men, welcome to the Heather Hirsch podcast. I am so excited to have you on. And obviously, we've known each other for a really long time. If anyone doesn't know you, I can't imagine that. Actually, I remember the first time I met you, I think it was at the Ishwish conference. Yes. And I was like, oh my gosh, we have so much to talk about. But welcome. And go ahead and do the usual. Introduce yourself. And we have a lot to talk about today.
We do. So nice to see you. Thank you for having me. And congratulations on your perimenopause book.
Oh.
So important.
Yeah, I'm so excited.
Yes, it's great. So yes, Dr. Corinne Men, OBGYN and a menopause specialist with a particular interest in really helping women who are the most dismissed in menopause. And that includes breast cancer survivors, but it's actually a big tent of women who I think don't feel part of the menopause revolution that's happening, right?
Yeah.
They feel left out.
Yes.
And one of the particular areas that I'm interested in is women who maybe don't fit in, that perfect box.
Category.
Yeah, the perfect category. They feel like, I've said before, like the weird Barbie in the crew, right?
Yes.
And this might be women with, premature menopause, surgical menopause, or other complex, maybe benign, but complex medical issues like endometriosis and other things. So that's a particular area that I love to advocate for.
Yes. I mean, you do such a great job on your socials. I always wish that I was reading the article. I go to you to find out what articles are actually out. And it's just amazing, what you've built. And actually, you've been doing menopause, perimenopause, and HRT for maybe longer than I have. When did you kind of go from delivering babies to, and of course, your personal story probably also really played a big role in this. But how long have you been taking care of women in the later reproductive care?
Yeah, so it all really goes back to when I was not old, I was young. I was 28 years old.
You're
and I was a baby. I was a second year OBGYN resident, and I was diagnosed with stage 2A breast cancer. And I was shell-shocked, thrown into this breast cancer treatment world. And basically, I was thrown into early menopause, twice temporarily, third time permanently when I had my ovaries removed. And I realized that I was not well trained to care for the average menopausal woman, much less someone with premature menopause or someone with a breast cancer diagnosis, right? So it was around that time, I was around, I'd say 33, 34, that I got involved with the Menopause Society, and I took the exam and got certified. And then left, doing OB and focused my practice on GYN only. And then over the past, I'd say 15 years or so, have really dedicated, my practice to these issues.
Yeah.
So, and now that's all I do is menopause care.
Yeah. Yeah. And you're such a warrior for that, underserved, I don't fit in the box menopause. So that not just your natural menopause, one day my periods just kind of started to slow down and then they stopped and I was 52. So let's talk about these underserved populations. We've talked before on our podcast about breast cancer survivors. And today we wanted to talk about not so much patients who maybe have had cancer. Certainly they can be involved in this topic too, but women who've been thrown into menopause early. And there's lots of reasons why. And this has massive impacts. They're not their typical menopausal patients, although that's what a lot of their doctors are lumping them into. So let's just start with what variety, what flavors does this come in? Who or what puts women into an earlier menopause?
Yeah, so this happens way more frequently than people realize. There are basically 1 in 8 women will enter earlier menopause, so prior to the age of natural menopause. That's millions and millions.
Lot.
It's a lot of women, right? And so that encompasses early menopause, which is prior to the age of 45, but also premature menopause, which is the most critical population for us to really consider, because we know that women who undergo menopause at age 40 or below, if we don't replace their estrogen, they are at risk across the board of, significantly increased rates of chronic disease, cardiovascular disease, 50 to 100% increased risk, dementia, neurocognitive decline, and depression, sexual dysfunction. I mean, the list goes on.
And on.
And so we've got super clear guidelines from all of the medical societies that it's really standard of care that we need to replace these women. And this is where we truly can embrace the term HRT, right? Because it's truly a full replacement. We really want to mimic the natural levels that these women would otherwise be getting unless they have a true contraindication. But that doesn't necessarily always happen, as you and I both see in our practices.
Yeah. I always say it's kind of like having type 1 diabetes. Yes. You need the insulin if you're a type 1 diabetic. If you've had or lost your hormones before age 40, you need the estrogen. And so that's really, really important. So who could this happen to?
It can happen to lots of women. So I think, the rates are like when you look it up, they say about 3 to 4% of women. I suspect that number is slightly higher.
Yeah.
And, premature menopause can come from iatrogenic causes, meaning surgery or medications. And so certainly there are, cancer patients who are in this category. But there's a lot of women who have benign conditions. So endometriosis is one of them. Mm-hmm. Someone who has had a risk-reducing surgery. This is a particular passion of mine, as I'm a BRCA carrier myself. Yeah. So women who carry a BRCA mutation, or there's other mutations that, are diagnosed.
Tons now.
There's tons. It's not just BRCA. But these women choose to take their health in their hands before they've ever had cancer.
Yep.
And so they're being proactive. They remove their ovaries. They have something called a risk-reducing oophorectomy. Sometimes they preserve their uterus, sometimes not. And they're thrown into surgical menopause so that they can lower their risk of ovarian cancer, which is important.
Great.
That's important. But I tell these patients, no, you can have your cake and eat it too. You can lower your cancer risk, or you could treat your ovarian cyst or your endometriosis or whatever the reason is that you're being put into this early menopause. But we can also give you back your hormones. And if we don't, if we can't for some reason, then we must have a very proactive plan, because I love that analogy with diabetes. Mm-hmm. If you don't replace the hormones, you better damn well have a good reason why you're not.
Yep.
And if you absolutely can't, well, then you have got to be all hands on deck to help those women manage that. And what we're seeing is that is not happening. No. And in fact, I think it was about 2 years ago for OBGYN, for us to get board certified and to have maintenance, we have to read articles. And one of the articles was this study, looking at women who had benign reasons for an oophorectomy. What percentage of them, premature, surgical menopause, what percentage of them were being offered hormone therapy? And it was, about 50%, and the duration was only for about 5 months, and very few had bone density tests done or lipids done. And so the article basically cited fear and misinformation about the Women's Health Initiative and lack of clinicians being educated in menopause. So they just literally did not know what to do.
Yeah.
But this flies in the face of what the guidelines tell us to do. So there's a big disconnect.
There's a problem, right?
Big problem.
The next question is.
Yeah.
What is the problem?
Yeah.
Right? What is this problem?
Yeah.
Why is there this big disconnect? You and I both know, but let's say it out loud. Why is this a problem?
The problem is that there is not nearly enough recognition of the normal physiologic process of menopause.
Let alone,
when it's, induced early or happens early for whatever reason. And if you think OBGYNs are not being trained, well, we know they're not, right? We know family med doctors and internal medicine doctors are not being trained in this. And then, the subspecialists, whether it's the GYN oncologist or, the medical oncologist or, whatever, they are certainly not. And so, women are approaching, or dealing with this without a population of clinicians that really have ever even heard of what to do. And there's so much fear, so much fear and misinformation. We love the WHI, you and I, because we laugh about it. We love it. We don't want to throw the baby out with the bathwater because we know the safety of hormone therapy. And we know that the fear from that study should never be translated into younger women in particular, particularly the premature menopause population, which the risks that were, touted, which were not even real risks half the time, just simply did not ever apply to a 35-year-old who's having her ovaries removed because she carries a BRCA mutation and she wants to lower her risk.
It's a completely different population.
Totally
It's a completely different pathology. It's a completely different makeup, right? And we learned in medical school, I mean, we got like a tiny training, not on menopause, but on like epidemiology and how to like study research papers, that the research has to apply to the population. And that's exactly the problem, is that this research doesn't at all apply to that younger population. So if doctors are just now getting some education on menopause, which they haven't, and we still have a ways to go, there's no way they know about the subtypes of menopause.
Yeah. That's the problem. And so what happens is, and even amongst menopause specialists who are trying their best to serve patients. And some of these, clinicians are newer to the whole menopause care, and it's great that they're doing it. But then when they get slightly more complicated or tricky patients, they're kind of lost, unfortunately. And so I know you and I are both super passionate about educating fellow clinicians in that, because we would not take a man's testes off. Right? We wouldn't castrate a man at age 28 or 32 or 40 or 42 and just say, see how it goes. Let's see how you feel at your post-op visit in 6 weeks. We just wouldn't do that. But that is routinely what happens. And I hear from patients all the time. My doctor says, well, we'll deal with that. We'll just see how you feel.
When we get there.
Yeah, we'll see how you feel. Yeah. Or this bizarre fear that if you restart the hormones immediately, you're somehow going to make this woman who already
had her hormones,
had estrogen when she went into the OR, and now you're afraid to give her estrogen that it's going to cause her to have a stroke or a blood clot. It makes no sense.
I know. I'm sorry. I keep answering all of these.
Because we see eye to eye in this, because we know this is basically the facts. I mean, unless you have a true contraindication, you should be waking up in the OR with your patch on or your prescription for your whatever your appropriate dose and formulation for your estrogen is, because you don't go from here to zero overnight and not have any repercussions.
Right. And this idea of let's see how it goes. Some of the things you're at risk for, cardiovascular disease, bone loss, you can't feel. So the women are they feel probably the symptoms, but they're like, well, I'll stick it out like everyone told me. But no one told them you're at major risk for osteoporosis. 1 in 2 women are going to have an osteoporosis fracture, you're at major risk for heart disease, the leading cause of death in women. And, therefore they are left just alone and isolated. So I've heard you say before that this lack of training or this ignoring is basically medical malpractice.
It 100% is.
Yeah.
Because, I'm not talking about gray areas here. And we can discuss separately, and we have how to, manage the more complicated patient, like someone who had a history of breast cancer or a really complicated advanced GYN cancer or something like that. What I'm talking about are women who have benign reasons why they've lost ovarian function. Mm-hmm. And it's this under recognition of the early and the premature menopause. All of the medical societies have really clear guidelines on POI, premature ovarian insufficiency, and how to prescribe, and that these women need higher doses of hormones, and that we have to monitor their chronic disease, risks. But somehow that's not translating. So even the women who get the hormone therapy, I see this all the time, they're put on substandard doses.
Yeah, something my 62-year-old might be on.
Yeah. You don't treat the 30-year-old the same as the 62-year-old, right? Yeah. And then the other thing is we're not also recognizing that the ovaries produce testosterone, right? And, we do have data, not enough, we need more, but we do have data that women who lose their ovaries before the age of natural menopause are losing a source of testosterone. It's not the only source of testosterone in your body, but your levels are much lower, and that their sexual function, as well as their overall quality of life and well-being and other symptoms, are likely strongly impacted by that abrupt loss or lowering of their testosterone. So that's an area that is really underaddressed.
Completely underaddressed. Yeah. I mean, the whole data, the whole topic of researching testosterone in women in general still needs to be done, and also in our younger populations. Yeah. You mentioned premature ovarian insufficiency. Yeah. Briefly tell everyone what's the difference between having your ovaries surgically removed.
Yeah. So premature premature ovarian insufficiency, it's kind of a blanket term. And, there's a population that we call it idiopathic. We don't know why, right? There's probably hereditary genetic reasons why a woman just happens to go into menopause, particularly early. Certain medical conditions, autoimmune conditions, certain exposures in their life could, put them into that earlier menopause. Women who have had just their uterus removed are, and it's really interesting. They are assured by their doctors, like, okay, we're going to preserve your ovaries. We're going to take out your uterus because you have heavy bleeding or fibroids, which is important. You know, we have great reasons why we sometimes need to remove a woman's uterus, and it can vastly improve their quality of life because they're not bleeding, they don't have pain. But they're not told that you're likely to enter menopause anywhere between 1 and 3 years earlier, which then means that the perimenopause is starting that much earlier, right? But they don't have the telltale signs of, they're not bleeding anymore. Right. They don't have the bleeding sign. So they don't realize that when they have like suddenly new onset of anxiety, or they're not sleeping as well, or sex is painful, that they're like, oh, but I'm too young for menopause. I still have my ovaries, right? So that's an interesting population of patients that are, impacted.
Totally. So you're a surgeon. Why does that happen? Does it have to do with? I always kind of said, I did surgery for a year and then I couldn't stay up all night and do it. But is it the way? Is it have to do with? Is there any data of maybe how bad the endometriosis is? Where do you put those little ovaries? Where, Dr. Men, do you put the ovaries after you take out the uterus? What causes that earlier?
They don't know exactly, but I think it's important to understand that when we take a uterus out, we're clamping and cutting off the uterine artery, right? And there's branches off of the uterine artery that have a collateral blood supply to the ovaries, right? So the ovary has its own artery supply, the ovarian artery, but there's collateral blood flow, right? That does get clamped off. So we suspect there might be some type of, blood venous insufficiency. So, the ovaries aren't getting everything it needs. So that's one reason why they theorize that, ovarian insufficiency can happen earlier.
Yeah.
There's other more complicated, interesting reasons. There's some data about some signals that come from actually the uterus itself and feedback to the ovaries. And so we don't know exactly. And certainly you mentioned women who have endometriosis. So sometimes when we're going in and removing the uterus, we're also ablating areas of endometriosis implants. And some of those areas can be near the ovaries and the tubes. And, that can also impact ovarian function, so I think this is where you have to believe women when they come to your office and say, I know I still have my ovaries, but doctor, something's different, like these women and it's part of pre-op counseling, right? To be like, hey, listen, we're going to remove this uterus, but just heads up, I want you to have this checklist so you know what early menopause could feel like, because you're not going to have the period to tell you that, right? So this is about pre-op counseling. And so I think this is really, really important, not just for an endometriosis patient, but getting back to the BRCA previvors.
You got it. Yep.
Because these women are making really tough, but also planned decisions. Like they're making a decision. I'm maybe having a prophylactic mastectomy, having a prophylactic BSO to lower my cancer risk. And so there's time to plan. These are not done emergently. There's literally no excuse for these BRCA previvors to have to find doctors like me and you months, years later that I'm like, wait, you've never had a contraindication to hormones. And in fact, this is not new news. In 2016, Dr. Susan Domchak, who is the leader at the Vassar Center at Penn, which is for BRCA research and BRCA carrier care, wrote the practice pearl for the Menopause Society that said women who carry the BRCA mutation should not fear early removal of their ovaries out of fear that they're going to be denied hormone therapy, regardless of whether they've had their prophylactic mastectomy. And this is really an interesting point because there's this lot of idea that they have had their breasts removed also. And there are many BRCA carriers who choose not to have a mastectomy, but to do enhanced surveillance, screening, and not a prophylactic mastectomy. But many of those women who still have their breasts are told, no, you can't. And that's actually not what the guidelines say.
Yeah. So, gosh, I have 2 questions left, right? What can women who are in this situation do? And how do we improve this as healthcare professionals ourselves, right? So what do you want to tackle first?
So for the women's point of view and what I would advise them, no one's coming to save you. I hate to say it. You have got to be the CEO of your own health. It's not that your doctors don't care. Many of them were just not educated, and it's your job, it's your health, it's your life, you're worth it. You have to be an educated consumer, an educated patient. And we have great resources. We really do. There are lots of nonprofit educational resources out there. So, if you are considering having surgery for whatever reason, and the idea that early menopause might be in the picture, you have to demand a discussion before that medical intervention is done, right? So it's a lot of responsibility on patients who are already maybe managing complicated medical things, but you're worth it. That's what I tell patients.
I love that.
From a clinician side, it's okay to be humble and say, I don't know. I'm nervous. I don't know. If you've got a patient where you're unsure if hormones are the right thing or what you should do or how you should manage that. And there's something called the internet, right?
It's at your fingertips.
It's at your fingertips, right? Yeah. So you can go online and you can look it up. You can go to places like the Menopause Society or ISHWISH, the International Society for the Study of Women's Sexual Health, or go to a place like the Academy and take a course, read a book, and it's okay to say to your patient, you know what, I'm actually not sure, but you bring up a great point, and why don't we have a follow-up, right? And I think it's okay. Like, patients really are okay with you telling them, I'm not sure.
Yeah.
And I've had a lot of complicated patients with menopause issues for a variety of things. And I say, okay, well, this was a great meeting. We got a lot of information. Yeah. But I don't actually know what's the next best step. So let's do X, Y, Z. I'm going to give you some homework. I've got some homework. And then we're going to come back. But what happens is there's just this fear-based reaction.
Yes, of just this knee-jerk, no.
And it always comes down to breast cancer. Right. I'm telling you, literally the fear of breast cancer across the board is the biggest barrier to both women making decisions about hormone therapy and doctors prescribing it.
Yeah. And what I've always admired about you, what I get to actually see you do all the time, is start to break down these silos. And I think that over time, right? My hope is in 5 or 10 years, these women do have, there is a menopause hallway, right? Or there's a menopause division, or there's a menopause, consult room next to the pre-op room where it's actually multi-specialty and you work together. That would be my dream. How do we get there?
It's going to happen, but it's happening very slowly. And so this is why I tell women, no one's coming to save you. These issues are systemic. There's a huge problem with graduate medical education when it comes to women's health. It's siloed and it's just not taught, right? It's still not taught. I was at ACOG this past spring, and there was a lot of early career, young residents, or
I saw you interviewing all of them.
Yeah, there's some medical students there, and they were lovely. They're so motivated. I love the future of medicine. Yeah. And I was asking them, I'm like, are you being taught about sexual health besides just preventing STDs and pregnancy? They're like, oh, I think there was a lecture during our psychiatry lecture. I was like, oh my God.
Oh my gosh. Yeah.
And do you know what the genitourinary syndrome of menopause are like? No. And so, So, and these were young medical students, doctors who were interested in the field of OBGYN.
Yeah.
So, we've got a lot to do. Yeah. And there's this trickle down economics kind of idea that it's going to slowly trickle down.
And it starts from the women.
But it takes time. Women are demanding it, right? Yeah. And so I also sympathize with the doctors though, because we know they're being asked to see patients in 10 minutes, sometimes less. With all sorts of other pressures, administrative pressures, charting, EHR, email, lots of uncompensated time, right? Yeah. And medical malpractice, medical legal pressures. It's tremendous, right? And so I'm not really sure, how they're able to manage all of this, right? And so, we really, need to be sympathetic to what the doctor's dealing with as well.
I agree. We need to actually create better systems. And, maybe the future with AI and all these things, maybe it'll get a little bit better and take some of those burdens off.
No, there's hope there, yeah.
But you're right. It's complicated for everybody. It's complicated on both sides. But
It is.
I mean, shedding light on this topic, identifying these patients. So hopefully if you're listening and this is you, follow Dr. Men, because you're a fierce leader in really defining these differences and showing the research right on your pages of what women can point to, how they can go to their doctors. I love what you said, advocate for yourself. And then we're working really freaking hard to help the healthcare community do better. So, thank you so much for being on the show. Thank you for being a fierce advocate, someone I look up to, and I hope to follow in your footsteps. So thank you so much for being on the show.
Thank you.